very difficult task in 15 minutes to describe the discrepancies between men and women and to try to ask this exist between females and males with hypertension. So there are several important issues concerning this point. The first one is epidemiology, then the risk factors and target organs which are damaged not equally. Of course, there are several concerns in pathophysiology, in treatment control and possibly drug choice. There are discrepancies in compliance between females and males, and possibly there do exist several discrepancies in
the risk assessment and the risk reduction during antihypertensive therapy. There are about 10 reasons why hypertension should be gender-dependent issue. The first one is, I think, life expectancy, because in the majority of countries, life expectancy in females is a little bit higher or even significantly higher. And the probability to have hypertension in females is higher. Risk factors are a little bit different, especially several behavioral risk factors such as smoking, alcohol consumption, physical activity, the prevalence of obesity, and many others. Of course, there are serious discrepancies in pathophysiology, beginning from the fetal programming of the renin-angiotensin system and going to the impact of sex hormones in blood pressure regulation, salt sensitivity, sympathetic nervous system activation, the role of endothelin and the role of kidney. There are discrepancies in the hypertension awareness, compliance, several reports about drug efficacy, target blood pressure achievement and treatment resistance, especially the prevalence of the resistant hypertension, target organ damage, several complications, and females, unfortunately, if they do have the several complications, they usually have worse outcome, and more possibly some discrepancies in the positive effect of blood pressure reduction. If we look at the prevalence of hypertension, in general we can see that the current prevalence and expected prevalence in 2025 is more or less equal, and in several regions there is a predominance of males and in several regions of females. For example, if we look to the Eastern Europe, so the prevalence of hypertension is in majority countries is a little bit higher in male gender. But at the same time, if we look at in general, the prevalence of hypertension seems to be more or less equal in male and female gender. However, it is indeed a factor which strongly depends on the age of the population. And under the age less than 45 years, the male gender is predominating, and after the 65 years, and especially in the elderly, females are more frequent to have hypertension, and this is very important for analyzing and sub-analyzing clinical different. For example, the same situation we see in Russia in the very large epidemiology survey. So in younger age, males are more frequent, in older age, females. What about blood pressure control? There are a lot of data concerning this point. In majority of European countries, the control is more or less equal, but a little bit better in females. Here you can see the recent publications about blood pressure control in Austria. At the same time, in several other countries, there are a very large discrepancies. For example, in Turkey, between blood pressure control in males and in females, and females are treating their hypertension much better. The same we can say about countries of Eastern Europe, and here you can see the data again from the recent publication from Russia, and for example, in Russian Federation, so the blood pressure control in females is more than 2 times higher than in male gender, and the awareness and the regular intake of medication is also higher.
And at the same time, if we look at the age of these patients, so the easily achieved blood pressure control can be seen, for example, in male, and at the same time, females are a little bit more difficult to be under control after the older age. And here you can see the data from the Canadian population, where they showed that after the age of 60, in female, the achievement of blood pressure control is a little bit more difficult compared to male gender. So summarizing the epidemiology, there are of course gender discrepancies in hypertension prevalence and blood pressure control. And females in majority of countries, they have better blood pressure control and better awareness and better compliance with antihypertensive medications. But in the elderly, the blood pressure control in females can be challenged. Of course, prevalence is less of smoking is lower in females. You can see again the data from the ESS study, which are not published yet, between the huge discrepancies between prevalence of smoking between males and females. At the same time, the importance of abdominal obesity can be also different. For example, if we can see again to the data of the Russian study, we see that the prevalence of abdominal obesity is higher in male gender compared to female gender. Take into account all the international important things. We can stress that prevalence of obesity in females is significantly higher in African Americans. There is this association of obesity and hypertension, and it is a little bit stronger in women, especially in postmenopausal women. But for male gender, very important is abdominal obesity, and it is more stronger. Going to our personal data from St. Petersburg, we can say that the occurrence of the concomitant hypertension and abdominal obesity together is higher in male gender compared to female. Another important issue is the female-specific risk factors. They are not very frequent, but they are important for the lifetime life of the woman and the development of cardiovascular risk as well as hypertension and its complications. First of all, important, of course, is polycystic ovarian syndrome, the history of preeclampsia, as well as several not so well-known risk factors, for example, parity, miscarriage, preterm birth, and stillbirth, and several others. What about target organ damage? Here on this slide, you can see, so in red, I mentioned those target organ damage that are considered to be more typical to male gender, to female gender. It's LVH, diastolic dysfunctions, the development of stroke and transient ischemic attack. In blue, I mentioned the risk factors, especially target organ damages, which are in majority of studies mentioned to be more prevalent in male gender, and this is first of all the kidney function. It was very long ago shown that the prevalence of LVH is also dependent on the age and sex, and under the age of 30, male gender is predominant, and after the age of 70, again, in the elderly, LVH is more typical to female gender. Here are the data from the St. Petersburg from the hypertensive females, and you can see the rapid increasing of the prevalence of LVH since the age after 30. Compared to other markers of the target organ damages, only the LVH is more prevalent in the elderly population in female gender. All the other markers of the vascular dysfunction appear to be either equal or more prevalent in males. Female during the whole life is a little bit approaching due to several very important life events such as pregnancy, and the postmenopausal changes is approaching to the higher sympathetic activation and developing of the metabolic syndrome. And of course there are very important factors such as the history of preeclampsia and weight gain after the age of 50. And we all know the importance of the sex hormones, especially estrogen level, for the development of atherosclerosis. And while in younger age, the estrogens have a protective effect, in the older age, for example, this is the explanation of some compromising effects of hormone replacement therapy. The level of the sex hormones can develop to the increasing rate of atherosclerosis changes. Here you can see the vascular endothelium of the reproductive age and the postmenopausal women. And you can see the huge discrepancies, and from the theoretical point of view, of course, the treatment of such patients and the aggressive treatment taken for them blood pressure lowering drugs and as well as statins should be more intensive. We all know that the coronary artery disease has the negative prognosis in female gender, including the complications after bypass surgery. I want to stress you that a stroke has also very important sex features, because women, they have the higher lifetime risk of stroke, and they have, unfortunately, the worst outcome after stroke. And this is also important thinking about treating these patients. Going to the pathogenesis, and from the theoretical point of view, there are a lot of things that do occur in females during their life compared to male gender. And in male gender, the developmental things are much more important, and they include the decreased nephron number in the fetus, and several later during the life testosterone-dependent changes in the renin-angiotensin system development. And of course, very important thing is the endothelin mechanisms and the response of blood pressure to endothelin and kidney response are also sex dependent. In females, in the young adulthood, estrogens and antioxidants are absolutely different. That is why we do consider that the hypertension and postmenopausal women have a very specific pathogenesis, and the development of endothelial dysfunctions and the increased risk of salt sensitivity are highly important in the postmenopausal women compared to male gender. Here are the data from the large survey of postmenopausal women in St. Petersburg compared to male gender. You can see that the prevalence of salt sensitivity in postmenopausal females is dramatically higher compared to the younger females. So now, coming from all this theoretical point of view, coming to practice, what do really the guidelines and the clinical trials say to us, and what evidence do we have to different treatment? If we look to the blood pressure goals, so we can see that there are no specific blood pressure goals for females compared to males, and all these things depend only possibly of the age and of our patients in the current guidelines. If we look to the specific populations, women, so in the guidelines there is there is important information concerning treatment hypertension in pregnancy. At the same time, we do not see in the guidelines any specific things concerning treatment with females which are non-pregnant. From several countries, there are reports about real-life discrepancies between administration of different drugs in different genders. For example, there is a Polish study which reported that physicians do not administrate beta blockers to female gender. At the same time, in this study, it was shown that efficacy was even higher in the younger females compared to males from beta blockers. From the published study, we can summarize that when we use, for example, combination therapy of different antihypertensive drugs, the effect on blood pressure is more or less the same, and there are no proven discrepancies between efficacy. Here you can see the data of the very large registry of St. Petersburg. These are the data for more than about 60,000 patients, and this is the distribution of administered antihypertensive drugs. And you can see that in general there is equal administration in females and in males, but a little bit more frequently we administrate to female patients diuretics. And this is again from the pathophysiological point of view, because there is no any evidence from clinical trials or the real guidelines to do this. Let us look to the analysis of the blood pressure lowering trialist group, which was done in 2009 compared the risk reduction. And you can see that there is no effect of gender on the effect of different drugs on major cardiovascular events, and both males and females they do benefit from the blood pressure lowering equally. As it is written in the guidelines, the benefit of antihypertensive treatment in men and women, both blood pressure lowering and reduction in outcomes, was similar in both sexes. And there are no sex-related differences in response to various classes. For the sex differences in the consumption of antihypertensive drugs remain unknown, but in many countries they really do exist. At the same time, if we, for example, look at the data that we obtained of hypertensive drugs in postmenopausal women, we can see that for equal number of non-responders to beta blockers, ACE inhibitors, or centrally and at the same time the response rate for diuretics is really high in of
patients. So coming to a conclusion, I would like to stress that at present time there is no evidence for different treatment targets in hypertensive men and women, as also specific recommendations for the drug choice. However, developmental issues, pathogenesis, blood pressure and target organ damage patterns suggest that certain discrepancies in treatment response and risk reductions should exist, and possibly we did not reveal them in the clinical trials. So this needs, I think, further investigation with an appropriate design of the clinical trials, as all the data that we can measure and discuss now is usually the sub-analysis. So we never did a special trial that should compare the risk reduction in different complications in males compared to females. Thank you for your attention.